Good evening, everyone. Thank you very much for attending the DC&R Journal Club. Today we are, of course, in sunny South Florida in Tampa. And so this is our team. And of course, Dr. Galandiak is the editor-in-chief, and so she oversees all of the journal clubs as well as the journal as a whole, of course. This is, of course, our disclaimer, which we always put, and the brief outline of the meeting. I guess I visited Tampa about 3 years ago, I think, when the ASCARS meeting was there. And I remember jogging along the water actually near the conference center. And as I was jogging, I saw a dolphin skipping in the water, which was a wonderful memory and a wonderful feeling. So it really seems like a fantastic place. And I'm jealous of the people that work there. Now, as per kind of a routine that I have about a fun fact about Tampa. So Tampa is the only city in the world to be invaded by pirates every year for the Gasparilla Pirates Festival, which is bizarre when I read about it, but it'll be interesting to see. And I can only assume that people dress up like the Seinfeld episode where everyone wears a puffy shirt to work. But we'll get the details of the Pirates Festival and other things about Tampa from our panel. And in the panels, particularly, I want to thank Dr. Robert Bennett and Dr. Jorge Marcet, who've worked behind the scenes to set this up. So I'm very indebted to both of them. Dr. Marcet, of course, is the professor of surgery and the chief of the division, and as I understand, founded the program. And so I think it's most fitting for him to sort of introduce the city, introduce the hospital, and the excellent panel that we have.
Thank you, Dr. Bolchinski. It's a real honor to be invited to host this program. We're here live from Tampa. We're at University of South Florida and Tampa General Hospital. I founded the program a number of years ago. I saw this as a wonderful opportunity to grow the academic practice of colon and rectal surgery. So we started our colorectal fellowship 15 years ago. After 5 years of training, we upped our program to 2 fellows per year. And then 3 years ago, we added a research fellowship. So this is a basic science research fellowship. Tonight we have Dr. Yeatman, a colleague of mine for the last 30 years, who will speak to some of our basic science projects and translational projects that we have going on. But it is true, we are a city that gets invaded by pirates once a year, and people do dress up like pirates and wear beads, and it's fun. I would like to actually ask Dr. Bennett to introduce our panelists. Dr. Bennett, as you all are aware, trained USF in his general surgery, but then I sent him away. I said, if you want to practice here, you go do your fellowship somewhere else. And so he had the great fortune of working with Dr. Galandiak, and we had the great fortune of bringing him back. So with that, I'd like to pass it on to Dr. Bennett to introduce the rest of the panelists.
Thank you. And yeah, thanks, Vlad, for the invitation to host the Journal Club. I want to talk a little bit about Tampa first before we jump in. I'll just take a few minutes because I think it's a wonderful place and I want to promote it. And hopefully a lot of you on here tonight will be here next year for ASCARS. But Tampa is actually, despite the name University of South Florida, we're actually located about middle of the state on the west coast of Florida along the Gulf of Mexico, or not to get political, but depending on which political party you subscribe to, the Gulf of America. And we're in the Tampa Bay region here. Actually, this is the area where the original Spanish settlers landed in the Tampa Bay area under the leadership of Ponce de Leon in the early 1500s. But they decided to really trek eastward and settle the eastern and northern parts of the state first. And I think if they had to do it all over again, they might come back and start here. But it wasn't until 300 years later or so that members of the U.S. Army came back to this area and set up Fort Brooke as a strategic fort to defend the Tampa Bay area. It really wasn't until 1845 that the Tampa Bay region became a part of the United States. And really what kind of drove the growth, a couple industries, as we were talking about earlier with Dr. Bolchinski, the cigar industry and actually some railroad magnates really grew this region into what it, at least financially, what it became eventually. And actually, interestingly enough, another little fun fact, the Tampa Bay area, Tampa was really the home to the world's first commercial airline service. The St. Pete Tampa airboat line flew from St. Petersburg across the bay to Tampa, and that was the world's first commercial airline. in the world. So that's kind of a neat fact. Today, it's home to a MacDill Air Force Base, which is the headquarters of U.S. Central Command and the U.S. Special Operations Command. It is also home to 3 professional sports teams. We have major U.S. professional sports teams, the Tampa Bay Rays, the Tampa Bay Buccaneers, and the Tampa Bay Lightning. It's obviously home to, the area is home to world-class beaches, some of the best beaches in the country. As we were mentioning before, obviously the Gasparilla Pirate Festival, the Invasion of the Pirates. It's a Mardi Gras-like festival, one of the largest parades in the country, and the pirates invade the city and get the key to the city every year. So that's a really fun event. It's really evolved into a multi-month series of festivals with music, film, food festivals throughout a course of about 3 months. And really national publications, national media outlets have taken notice within the last couple of years. Time Magazine and U.S. News and World Report have both ranked Tampa in the top 50 places in the world and top 25 in the country to live in. And then, our professional societies as well have taken notice. Society for Surgical Oncology just wrapped up their annual meeting here in Tampa this past weekend. SAGES will be here next year, and ASCARS will return next year to Tampa after a very successful meeting in 2022. This is just some pictures of our facilities here at Tampa General Hospital in the top left, being on an island there next to the water with downtown in the background. Our brand new medical school opened in downtown a couple years ago there, the top right picture there with research facilities and all our medical school classrooms, et cetera. The bottom left is a world-class simulation center that we have here in affiliation with USF called Center for Advanced Medical Learning and Simulation, or CAMLS. And we opened within the last several years, first of its kind in the state of Florida, Comprehensive Inflammatory Bowel Disease Center. In combination with our colorectal division and our gastroenterology division, we have 2 specialists in GI who focus on inflammatory bowel disease, have advanced training in that field. And also, as Dr. Marcet mentioned, 2 years ago, we started a research fellowship with the support of a generous donation from a grateful patient. And I think it's a nice little tie-in to our topic tonight because the gentleman who made the donation actually was on a watch and wait protocol. So it kind of fits in really well with this. And as you can see, they're centered there. Last year, again, U.S. News and World Report ranked us, our GI and GI surgery division, of which we're a huge part, number 1 in the state of Florida and number 15 in the country. So a lot of great things, a lot of exciting things happening here in Tampa and at USF. I think a lot of what we just talked about is what really has drawn most of us here to Tampa. You met myself and Dr. Marcet already. Dr. Trzynski, who's also on the call here, he joined us a couple years ago. He's a professor of surgery and started his academic career at Georgetown University and had a foray into private practice before coming and joining us a couple years ago, and has been an absolutely wonderful addition to the team. Dr. Lisa Modgill sitting with us here in the room. She's our program director and chief of general surgery at the Tampa VA. Dr. Carolina Martinez is going to be one of our discussants tonight. We were fortunate to recruit her here to complete her colorectal fellowship, which she graduated in 2020, and we were very lucky to hire her on as faculty. And our newest addition, Dr. Cavallero, who's our other discussant, joined us by way of Mass General and Cleveland Clinic for his colorectal fellowship, and he's been with us for about 1.5 years, I think now. So, and we'll meet Dr. Yeatman a little later. We're very lucky to have him with us, a very accomplished surgeon in his own right, and renowned scientist who runs a translational and basic science lab within our division. So we're exceedingly lucky to work, live, and play here in Tampa Bay, and looking forward to seeing everybody next year at ASCARS.
Thank you very much for that. Yes, very fortunate to have such an exceptional panel. Before we get started with the first article, we usually have a poll. And so the poll today is, what is the duration of surgical surveillance of patients with locally advanced low rectal cancer treated with watch and wait who go on to have a complete clinical response? So fill that out when you can. So our first paper comes from Holland and is part of the Dutch Watch and Wait Consortium, titled What to Do with Suspected Nodal Regrowth on MRI During Follow-Up in an Organ Preservation Approach for Rectal Cancer. The paper will be presented by Dr. Kaylee Smith, and then we have Dr. Carolina Martinez, who will follow with some expert commentary. Thank you very much, and please start when you're ready.
Hi, this is Kaylee Smith. Thank you so much for having us. So this paper looks at patients who have had nodal regrowth or concerning nodes on imaging. It's taking into consideration two subsets: patients who have undergone neoadjuvant therapy, mainly in this particular paper, patients who have had neoadjuvant chemoradiation or short course chemotherapy. Complete clinical responders in this group are somewhere between 15 and 30%. And then the small subset of patients that they also included were those who undergo local excision for early rectal cancers, a T1 or T2, with pathology consistent with high-risk histopathological features for nodal metastases who do desire organ preservation. Both of these groups do undergo surveillance at similar intervals, and the vast majority of patients in both of these groups have endoluminal recurrence when it does recur. And we picked this up with a combination of endoscopy, physical exam, and MRI. About 3% of the patients will have regrowth within the nodal basin itself, and this is much more difficult to qualify even with our advanced imaging technologies. And at present, we have no strict criteria for identifying nodal regrowth and no consensus protocol for diagnosis of these abnormal appearing nodes on imaging. And because of this, there are unclear next steps if there's no endoluminal regrowth noted, but changes in the lymph nodes on imaging. And this paper is working to basically do a retrospective review on how this is handled within these patients in this Dutch sampling. So as I mentioned, this is an observational retrospective study. Like I said before, there's two cohorts of patients. Those are on the watch and wait protocol who have had chemoradiation or short course radiotherapy, who have had a complete clinical response, and who have subsequent suspected nodal regrowth on imaging. And then the other cohort are patients who had an early rectal cancer, either a T1 or a T2, with features that are concerning for high risk of nodal metastases, whether it's EMVI, LVI, or perineural invasion, that had undergone a local excision as opposed to a TME. And these patients also were found to have suspected nodal regrowth on imaging. All of the patients were identified retrospectively from national databases and were undergoing follow-up at appropriate intervals every 3 months for the first 2 years, and then every 6 months thereafter up to 5 years. And this included endoscopy, physical exam, as well as MRI. They next looked at what the next steps were that we took in these patients, whether it was a number of adjuncts that we could provide, endorectal ultrasound with biopsy, repeat MRI imaging, PET scan, or just proceeding directly with total mesorectal excision. And the overall goal of this was to provide an overview of the diagnosis and treatment in these patients who have suspected nodal recurrence of their rectal cancer. So there's a total of 619 patients that were reviewed between 2014 and 2022. 27 of these patients had suspected nodal regrowth after chemoradiation or short course radiotherapy in that first cohort, and then 8 patients in that second cohort were suspected to have nodal regrowth after local excision. The median time to suspected nodal regrowth was similar between the two groups: 9 months for the neoadjuvant therapy group, and then 10 months for the local excision group. Of all of these patients, 28 out of the 35 patients had no endoluminal regrowth, and all of the concerning findings were found to be on imaging. 6 of those patients had endoluminal regrowth, as well as a possibility of some concerning findings on MRI. When we look at the breakdown, so 7 patients went directly to treatment, whether that was neoadjuvant chemoradiation therapy and radiation therapy, or just proceeding with TME. I'm sorry, I misread that. So 7 of those patients ultimately had that endoluminal regrowth that we had discussed, and they proceeded immediately with TME. In the group of 28 patients out of the 35 who had only suspected nodal regrowth, 10 of those patients underwent additional therapy, whether it was chemoradiation and then proceeding with TME. 1 of those 10 actually had stabilization of the lymph nodes after additional radiotherapy and avoided TME at that time. Of the remaining 18, 14 underwent a repeat MRI, and 8 patients within that group also had adjunct imaging, including additional MRI or PET CT scans or endorectal ultrasound. 13 of those 14 patients, based on the findings of those studies, ultimately underwent a TME, and then 1 on the retrospectoscope was found to no longer have concerning MRI findings on his index scans, and no changes on subsequent exams, and ultimately did not undergo surgery. And then 4 of the 18 underwent PET CT or endorectal ultrasound as opposed to undergoing an MRI. And again, all 4 of those patients ultimately underwent a total mesorectal excision. So in total of these 35 patients, 33 of the 35 proceeded to surgery. 27 of these 33 patients, or 82%, were found to have tumor within the nodal basins on pathology. Of the 6 patients who had no mesorectal disease, 5 of those actually had intraluminal regrowth, which was part of the deciding factor to proceed with surgery. In the patients who did undergo additional imaging modalities, there was only about a 4-month quote unquote delay in proceeding with surgery from the time of identification of these nodes. And long term, I mean, most of the patients did okay. 5 had extra mesorectal nodal recurrence, 4 had distant metastases, and unfortunately 2 were deceased from widespread metastatic disease. So in looking at the overall themes of this paper and, where the decision-making branched for many of these physicians, any endoluminal regrowth or very concerning nodes on patient or on imaging, all of these comers immediately proceeded with a total mesorectal excision. The gray area that they identified were those patients who are either hesitant to proceed with surgery or if there were lymph nodes that were somewhat concerning but unclear. Most of these patients underwent a repeat MRI within 8 to 12 weeks. Some of these patients underwent a PET CT or an endorectal ultrasound in conjunction with the MRI or alone. Size, shape, and character were taken into consideration, but are not always the best to evaluate these nodes as we don't have clear radiographic criteria in order to definitively say which are recurrent and which are not. And so per the documentation, the most decisive factor in deciding to proceed with surgery was persistent growth of these lymph nodes on the subsequent MRIs. PET CT and endorectal ultrasound can be appropriate adjuncts. PET CT can be quite nonspecific. Any sort of inflammation can have hypermetabolic activity. And endorectal ultrasound is often user dependent as well as institution dependent if it's available. And biopsy is not always technically feasible, and it becomes unclear what the next steps are if your biopsy is inconclusive. MRI is the best modality that we have. The sensitivity is 73% and the specificity is 77%, which is pretty good, but not perfect. And it leaves a lot of room for some false positives or false negatives in some of these patients. And so, the authors bring into question what the role for additional adjuncts outside of these are, whether it be things such as ctDNA or even AI modeling. The limitations for this study, it was a really small cohort. There were only 35 patients. It was a little bit of selection bias in patients who had clearly suspicious nodes on that first MRI, and there may be missing some patients who either had changing nodes later or nodes that were resolving. Because they were looking at a lot of the documentation, patient preference or physician clinical decision-making was not always super well documented, and so it was unclear at times whether it was patient-driven or physician-driven as timing to proceed with TME. So overall, their main conclusions and proposed algorithm for the diagnosis and treatment of this relatively rare finding that we see was that if you have any histology confirming regrowth or there's endoluminal regrowth, the decision is relatively easy to proceed with TME. If you have clearly new and large or very suspicious nodes on a recent MRI, they also would recommend proceeding with TME. And that's the next group of these indeterminate nodes or limited suspicious nodes on MRI, or patients who are very hesitant to proceed with proctectomy, repeating MRI in 8 to 12 weeks. At that point, if you see any enlarging nodes on TME, or on repeat imaging, they do propose proceeding with TME. And then if it still remains unclear after that MRI, after 8 to 12 weeks, considering adjuncts such as a PET CT or an endorectal ultrasound. The caveat to this is obviously patient counseling, and important to counsel these patients on the risks of forgoing TME with worse outcomes if they truly do have nodal disease. But they may consider using these diagnostic tools in patients who are hesitant to proceed with such.
Thank you very much for such an excellent summary. If we can have Dr. Carolina Martinez now for some comments. Thank you.
Absolutely. So first of all, I'd like to thank the authors for their work on this paper, and also thank you to the Society for allowing us the opportunity to discuss it today. What we can see with this article is that we're working with a very small, very select sample size. Out of the database, only about 3% of patients who were under a watch and wait protocol will return with nodal regrowth. And since there's not a standardized way to manage these patients, I think that this article provides us with some good insights on how to proceed. What I found was interesting is that 33 out of the 35 patients still ultimately underwent a TME, and that's 94% of the study population. For those who had immediate surgery, the decision seemed like it was fairly straightforward. They had very concerning imaging findings and they had luminal regrowth. But for those who did not undergo surgery right away, that's when the additional testing was then completed to determine what would be the next step. As Kaylee mentioned, the role of PET-CT and endorectal ultrasound, I think, is useful when you have a high index of suspicion for nodal recurrence, and perhaps you're recommending a TME, but the patient might be hesitant to undergo surgery right away. And so if there's something more that you can do that might give them the information that they need to proceed with treatment, then these may be very useful adjuncts. But again, MRI only had sensitivity 70 to 80% specificity for nodal recurrence, and PET-CT lacks the ability to detect these smaller lymph nodes. And endorectal ultrasound biopsies can be very useful when you're able to obtain the biopsy, but this is also very operator dependent. So consideration for future models are these artificial intelligence programs that the authors do mention as a new frontier. These may help improve our ability to detect these recurrences with greater accuracy. And I think that this is something to really look forward to. Yeah, despite the additional workup that these patients had, I also think it's important to consider the histologic findings that were reported. Out of the 33 patients that ultimately had a TME, 32 of them had confirmed disease on final pathology. And so I think that this tells us something about the tumor biology of the patient's disease, because regardless of whether the patient underwent surgery right away or if they received treatment in the form of re-radiation, as in this study, the vast majority of them still had disease at the time of resection. In my practice, a consideration would be the addition of perhaps using circulating tumor DNA testing as an adjunct in the decision-making process. Although there's still not enough evidence to really recommend its routine use for watch and wait patients, I still do find that it's a very helpful tool. A positive ctDNA in conjunction with abnormal imaging might sway me towards recommending upfront resection. But if there's a patient that's still very interested in a watch and wait protocol, perhaps you have the opportunity to check their tumor DNA. And if they have a positive circulating tumor DNA that then becomes negative after potentially also doing systemic treatment, and then if the imaging becomes negative, that may also give you the argument to continue on a watch and wait protocol if they have a complete response at that point, and potentially avoid surgery in a patient who's really averse to a TME. This is also particularly true for patients who underwent local excision. In this study, these patients did not receive any form of neoadjuvant therapy. So this may be a population where considering systemic treatment as well as monitoring circulating tumor DNA and irradiation may be an opportunity for these patients. There are some significant limitations to this study that should be taken into consideration. It's a retrospective observational study, so there are some issues with selection bias. It's also a very small sample size, and this can reduce the generalizability of the results. But I do think that there is also a role for systemic chemotherapy in this population, which was not specifically addressed in this article, but is certainly an important part of our watch and wait protocol. So I think there's still additional studies that need to be done to really understand which algorithm is best for this population. But it appears that ultimately a lot of these patients do end up needing to have a TME regardless.
Thank you very much. I'm going to put this to the panel just for anyone on the panel to make comments about the study as well. The other thing I just wanted to throw out there, and Dr. Bennett can distribute maybe who can answer this, sort of an observation that I have is that we have a rapidly growing trend to embrace watch and wait. And we have a slightly less, but also rapidly growing trend to embrace surgical dissection of lateral sidewall nodes, which seem like completely different directions. And so my question is, say for watch and wait, which as I understand you guys do you consider that for patients who may have suspected pelvic sidewall nodes? And secondly, if you have a person who has a complete clinical response in the rectum and TME, yet has a potential regrowth or a dubious lateral pelvic node, what would you do in that scenario?
Yeah, those are great questions. I think this is a kind of a vexing problem because I don't think we have a lot of strong data to really guide us. So, I think we're fortunate here to have a really strong multidisciplinary tumor board with really aggressive medical and radiation oncologists who all have a lot of experience with watch and wait as well. So I think we're fortunate to have their insight on all of this as well. I think the lateral pelvic sidewall nodes are a difficult problem. Obviously, that the lateral pelvic sidewall lymph node dissection is not a technique that a lot of us have done a lot of. So I think it is kind of a scary thought going after those. I think there is some good data to suggest doing that in that scenario would be worthwhile from a recurrence and survival standpoint. But I think there's also, depending on what kind of upfront therapy they've gotten, and when they got that therapy, I think there's certainly a role potentially for reirradiation as well in those patients, and certainly systemic chemotherapy, again, depending on what they've gotten up front. I think as Dr. Martinez and Dr. Smith both pointed out too, I think I'm very excited to see where emerging data on circulating tumor DNA and how the evolution of those types of tests really helps as an adjunct to all of this. Because if you don't find any other, solid organ deposits, then and you have a circulating tumor DNA that's positive, this question of the nodes, whether or not they're positive by imaging, I think that's a really fascinating adjunct that we have to really use in terms of deciding what to do next. So I'm sorry if I didn't answer all the questions. We can open it up to the rest of the panel.
Yeah, I think the lateral pelvic lymph nodes are important, and I think we need to hash that out a little bit. I looked to George Chang and some of the data that his team has released when looking at lateral pelvic lymph nodes greater than 7 millimeters in size being clinically relevant. And so I think in that situation, my particular patients, I would be a little bit more reluctant to offer a watch and wait with lymph nodes that are that large, or you see enlarging. I thought what was interesting about the article is they don't go into a lot of detail in terms of size of lymph node changes, and that would add some interesting perspective potentially to this article.
Dr. Bolchinski, you bring up an interesting dilemma, is what to do with the pelvic sidewall. And this article did not address that. They're talking about enlarged mesorectal lymph nodes after watch and wait treatment. And the pelvic sidewall should be included in the original radiation fields. And if we notice that there is a pelvic sidewall lymph node after treatment, first thing we look at is were they actually treated, and consider treatment if they were not adequately treated. So there may be room to retreat the pelvic sidewall. Pelvic sidewall recurrence is very unusual, and that would be very worrisome in a patient with that clinical scenario. So these are patients that would be less likely to recommend continuing watch and wait. At a minimum, treat with reirradiation and chemotherapy if that's a possibility. It's probably unlikely you would have an isolated pelvic sidewall recurrence without a local recurrence as well. But nevertheless, that would be a very worrisome clinical scenario of a pelvic sidewall recurrence. And we would probably recommend more aggressive treatment.
Thank you. So in the hypothesis of a complete clinical response in the rectum, but a dubious lymph node which has come back in the lateral sidewall, would you push for a TME excision or not? As in, like, would you take what is clinically complete pathological response, or would you just focus on the lymph nodes laterally? I guess that's something that I've had a patient like that, and I really don't know what to do.
Well, with the pelvic sidewall being in such close proximity to the rectum and mesorectum, I would do a TME at the same time as a pelvic lymph sidewall dissection. However, let's say you have a complete clinical response, just to change the subject a little bit, and now the patient has a hepatic metastasis. Do you do a TME then when you have a complete clinical response, or you just focus on the metastasis? And in that scenario, usually we just focus on the metastasis and continue careful watch and wait. We don't know the answer, obviously, but I think with the pelvic sidewall being in such close proximity, we're going to operate in the pelvis. To me, that's the time to do the TME.
I think that's very interesting. I had this comment for our next article, and we'll move on in a second. But one of the things that I have observed is I think we have changed our approach from aiming to cure to potentially tolerating a slow regrowth stage where we manage patients as if they have a chronic disease rather than cure them by saying, right, this is completely excised. And these sort of partial responses where they may have a bit of cancer, they may not, and we'll just observe them, is not, in my mind, is not really the same as saying we're going to excise for cure. But I think that's a philosophical kind of difference in view that I think has evolved. I don't know if anyone agrees with me or if you have other views.
I think we've learned that watch and wait is safe for many patients, and what I see here is the importance of continuing this careful surveillance as you'll pick up these isolated nodal metastases or local regrowths. And by doing so in a timely fashion can offer patients still offer them a curative resection. So I think what this article brings, as what was already discussed, is these are uncommon regrowths, isolated lymph node recurrences, but it's important for us to pick these up. And yes, I think philosophically we have changed how we manage rectal cancer to go slower, treat up front and observe and continue to observe and retreat if necessary. With the goal is that we're trying to avoid a major resection for the patient and its morbidity associated with that.
Thank you. Wonderfully said. Let's move to the next article then. And the second paper we have today is from a team in China with Dr. Yong Li being the senior author. The title of the paper is Effectiveness of Organ Preservation for Locally Advanced Rectal Cancer with Complete Clinical Response After Neoadjuvant Chemoradiotherapy, a Bayesian Network Meta-Analysis. So this paper will be presented by Dr. Jin Kim, and then we'll have Dr. Paul Cavallaro to follow up with some expert comments. Thank you. Start when you're ready.
Thank you, Dr. Potions. Thank you for the invitation and opportunity to speak. So neoadjuvant chemoradiotherapy and radical surgery for locally advanced rectal cancer results in 15 to 20% of pathological complete response rates. And omitting radical surgery on patients without viable tumor after neoadjuvant therapy can reduce the morbidity. Patients with a complete clinical response after neoadjuvant chemoradiation are likely to have no viable tumor. And some studies have explored the use of local excision instead of radical surgery in these patients. There have been a series of studies showing watch and wait of complete clinical responders is associated with lower morbidity and better functional outcomes with similar survival than patients who get radical surgery. Next, please. And the optimal management of patients with a complete clinical response after neoadjuvant chemoradiation is unclear, which is the basis of this paper. For the methods of this paper, they compared studies that had comparing outcomes of 2 or more treatment strategies for patients with locally advanced rectal cancer who have a complete clinical response after long course chemoradiation. And they pulled these studies from index databases. Complete clinical response was defined as no palpable mass on digital rectal exam, no residual tumors or fibrosis, no suspicious metastatic lymph nodes on imaging for the purpose of this study. And radical surgery was defined as total mesorectal excision. Local excision was defined as transanal endoscopic microsurgery as primary treatment for these patients. And the authors performed a Bayesian network meta-analysis and a traditional pairwise meta-analysis to analyze multiple variables, including local recurrence, metastases, 5-year overall survival, disease-free survival, surgical complications, and a permanent stoma rate. And we're not statisticians, but just so we are aware, a Bayesian network meta-analysis allows comparison of multiple interventions that have not been directly compared in existing publications by building a network of evidence and ranking the relative treatment effects. So in this study, they analyzed 11 articles from over 2,000 identified studies. And I just want to point out that 9 out of the 11 articles that were chosen here were retrospective studies. And overall, they had over 1,100 patients with complete clinical response. 49% had TME, 23% had local excision, and 29% were on watch and wait. And in the appendix of this study, they had multiple ways to do quality control, which I thought was a great way to this paper. And they found an association with possible publication bias with stoma rates and these interventions. And figure 1 in their main paper showed the odds ratio based on network meta-analyses, and they show that watch and wait is associated with a higher odds ratio for a local recurrence compared to local excision, and higher, much higher than radical surgery. Next, please. And figure 2 of the paper, they looked at the ranked analysis of treatments, and the way you interpret this is they have a threshold, the authors set a threshold of 0.9, and anything that crosses that number is a positive finding. So for local recurrence, for example, they found that watch and wait has the highest local recurrence, followed by local excision and radical surgery. They did not find any differences in distant metastases or 5-year overall survival or disease-free survival, but stoma rate was highest in patients who undergo radical surgery. So in conclusion, there's no significant difference in distant metastases or long-term survival. Radical surgery had the lowest local recurrence rate, but had more postoperative complications and permanent stoma rates. Watch and wait could be the optimal choice for patients to achieve a complete clinical response. The limitations of the study is the quality of the data. Only one of the papers was a randomized control trial. 10 out of the 11 were observational studies. There are potential biases in the data, despite the authors trying to do some quality control in their appendix. And the response assessment timing, methods, and definitions were inconsistent throughout the papers. The patient population were heterogeneous.
Wonderful. Thank you very much for that summary. If we can now have Dr. Cavallaro to make some comments.
Yeah, thank you. Thanks, Jen, for that summary of the paper. A few points to discuss. I think overall, well done meta-analysis. They hit on all the important points. They discussed the biases of all the papers that they included in their overall analysis. I think, just to kind of echo what Jen said about some limitations, and that's the major limitation, is that most of the studies used in the meta-analysis are retrospective in nature. There was really only one randomized control trial, and they compared local excision to radical surgery, so not necessarily a true observation, watch and wait with radical surgery. And in that study, there was no difference in 5-year local recurrence, metastatic disease, or overall survival. So, as all retrospective studies are, have some limitations on their own, they're all kind of independently affected by selection bias and maybe some factors that aren't accounted for. Like, why did one patient receive, X treatment versus Y treatment? Why were some patients, they were all complete clinical responders, so why did some have local excision outside of the randomized control trial? Why did one have local excision versus watch and wait? There may have been some other factors with that weren't necessarily accounted for. In addition to that, the paper only utilized studies, when you read the methods, that compared groups within a study. So it eliminated a lot of the seminal trials or seminal papers that described watch and wait, especially some of the ones from Brazil by Dr. Habergama that were more descriptive in nature, described the initial cohort of watch and wait patients after chemoradiation and compare them with patients who were pathologic complete responders by pathology after TME. So, it's probably missing some data that could have been included, given that the majority of studies in the meta-analysis were retrospective anyway. If there were 10 or 11 randomized control trials, I think it would have made sense to exclude some of those other studies. But since they were comparing across multiple different retrospective papers anyway, I think it would have been nice, and the paper would have been a little more powerful if they included some of those other trials. But when looking at the results, basically watch and wait is associated with higher local recurrence compared to a radical surgery, but overall similar rates of survival, distant meds. Obviously, surgery had higher rates of stoma and morbidity associated with surgery. And based on a review of the historical data, it's not entirely new in its reporting in terms of watch and wait having higher local recurrence rates, but this does represent, one of the largest meta-analysis of the data. When you look back at the initial reports and some of the bigger studies reporting on watch and wait, the rate of local recurrence for chemoradiation followed by watch and wait is about 15 to 30%, mostly within the first 2 years. I think this paper reported is 17%. And then when you compare it to some of the older trials looking at local recurrence after chemoradiation followed by TME, it's about 5 to 8%. So the group reporting it here is not necessarily new, but again, it's the biggest compilation of the data. At the end of the day, I think any decision, in medicine or surgery overall is risk benefit. And so for some patients, I think this data is good to show that the risk of decreased bowel quality of life outweighs the benefit of surgery. And so for some patients, especially in the light of similar overall survival, they have maybe a little bit more of a tolerance for an increased risk of local recurrence by organ preservation when compared to TME. And so they would prefer to go that route. And the same can be said for stoma rates. Now, I think a lot of the papers they used in this were sort of pre-TNT era. So with the advent of TNT, I think the data looking specifically at watch and wait after chemoradiation and without consolidation chemotherapy is not quite as relevant as our most recent NCCN guidelines sort of don't have that as a branch in the algorithm anymore. That being said, it does provide evidence that this could be an acceptable approach in the right patient, in the right context. Anecdotally, I've had one patient, an elderly female patient who had a complete clinical response after chemoradiation and then essentially was refusing chemotherapy, consolidation chemotherapy. But I felt pretty comfortable observing her, based on some of the papers that show this early on. So I think, it can still be applicable, in the kind of modern TNT era, but maybe not quite as relevant with the advent of TNT. So I'll turn it back over to Dr. Bolshinsky and any other questions.
Thank you very much. Now, please, any other panel members, if they have any comments, please participate. One of the things that I want to kick off more of a discussion was in relation to their definition of a complete clinical response. So they mentioned no palpable mass on digital rectal exam, no residual tumor or residual fibrosis, no suspicious metastatic lymph nodes on radiological images, which is fantastic. The concern I have is that some people's selection for watch and wait does not necessarily include only palpable tumors. And so my question to your team is, do you include sort of mid-rectal cancers or cancers which you don't necessarily are able to feel with a digital rectal exam when you select patients for TME, for watch and wait?
Yes, we in fact do. And so the endoscopic examination would be vital in this, obviously, as well as the radiographic imaging.
I agree with that. We'll look at mid to low rectal tumors to consider them for total neoadjuvant therapy, and then depending on how they respond, watch and wait. So not all tumors are palpable on initial and subsequent exam.
Thank you. And logistically, then, do you, particularly for international guests like myself, where there may not be as readily available flexible sigmoidoscopies in the office, what is your surveillance for these non-palpable tumors? How frequently would you scope them? And how frequently would you offer an MRI? And is there too frequent an MRI, less than every 8 weeks or something like that?
I can comment my own. I mean, I think we do it all pretty similarly. I'm doing in-office flexible sigmoidoscopies every 3 months on these patients for the first 2 years, and then every 6 months between years 2 and 5. And doing MRIs, provided they'll be done with insurance approval, every 3 to 6 months, along with their surveillance CT scans. Unfortunately, here we're a little bit limited based on what insurance will pay for, but that's kind of what I tend to do. I think you probably could get too frequent MRIs because, as we all know, especially after radiation, sometimes these are difficult to interpret. But I think that's also where you just have to put the whole puzzle together with your endoscopic findings, doing digital rectal exams, imaging. Like I said, I think that the emergence of circulating tumor DNA, I don't think that's standard yet by any means, but I think that's going to continue to get better and will be more a part of our surveillance protocols going forward. So I don't know if you do anything differently at the VA.
No, pretty much similar. Usually flexible endoscopy every 3 to 4 months, and the MRI is usually about every 6.
So for me, 3 to 6 months initially, right after treatment, I'm going to surveillance them a little closer. Patients in whom I see an incomplete response, that they stay on a 3-month surveillance. Patients that have a complete clinical response from the first visit on, a little more relaxed, 4 to 6 months surveillance. At least get an MRI in that 4 to 6 month range for the first 2 years. We do flexible sigmoidoscopies in the office. If that's not available, I would do a rigid proctoscopy. But yes, I do want to see the area, I want to palpate the area if it's palpable. And then CT scan once a year or sometimes every 6 months, just depending on the initial presentation. We follow CEA and we do follow ctDNA.
Thank you. One last question about this paper before we move on. So the authors state that 58% of the studies were from China or Korea and 63% of the patients were male. I guess from a physical perspective, we know that pelvic surgery is more favorable in female patients, and arguably Asian patients have a smaller BMI and probably are easier to operate on. Now, to what extent, if at all, would patient factors like this impact on your decision to offer watch and wait versus a proctectomy?
No, I think that male predominance of patients is typical for rectal cancer. I don't find that number unusually high. And I don't think that the male versus female anatomy would change our approach on watch and wait.
Yeah, I think it really comes down to, as Dr. Cavallero kind of mentioned, I think what a lot of this comes down to is just the patient's, good informed consent ahead of time and their own risk tolerance for, a little bit back to your comment about, almost managing this like a chronic condition. Do they have or depending on their life situation, are they somebody who is more inclined to want to take on a little higher risk for a local recurrence to decrease their chance of a stoma? And I think that when properly counseled, especially with the reassuring data on long-term oncologic outcomes, I think that's a perfectly reasonable discussion to have. And I agree. I wouldn't necessarily base my decision to offer watch and wait based on other patient factors like BMI or whatnot. I mean, certainly internally, I'm a little more worried about the operation on those patients, but I don't think it influences my decision to offer watch and wait.
Fantastic. Thank you. Now let's move on. We started talking about surveillance. So our poll for this journal club was specifically about surveillance, and particularly the duration of surgical surveillance of patients with locally advanced rectal cancer. So the options were 5 years, 5 to 10 years, indefinitely, and other. Stephen, have you got the poll?
Yeah, I'm just shared. It is, you can see a pretty wide distribution, almost, no predominant answer. Most people said 5 years, but there are many people that did list indefinitely or, the 5 to 10 year durations, and then, pretty much an even split, really.
Thank you. I guess, what do our hosts do? How long do you plan to survey these patients who have a complete clinical response?
So, we were involved in the OPRA trial, and we know from this trial that people that recur typically will recur in the first 2 years, and over 95% will recur if they recur within 3 years. Nevertheless, because this is something that's new, one of the concerns is, have we delayed the recognition of a recurrence? Could it be recurring longer than 5 years? 5 years being our traditional follow-up period for patients. So with OPRA, we have continued to follow these patients right now indefinitely. I counsel my patients that we don't really know how long that surveillance should be. Some patients just fall off. They just stop showing up after a while. But I would counsel that we continue to follow patients beyond 5 years. Patients, many of them like it. They like seeing you. It's fun to see them again. They're very appreciative of what you've done for them. And so, yes, I would counsel continuing to follow the watch and wait patients beyond 5 years.
Thank you. The reason I asked this, and it's been quite a few years since I did general surgical boards, as you guys call them, but I remember for breast cancer, there was a manifestation, I think, of angiosarcomas that develop 8 or more years after radiation. And I do worry with this big uptake and watch and wait whether, treating one thing may precipitate something else. But time will tell, of course.
That's definitely a concern that we have for our patients.
Right. Well, thank you all. Now we're going to move on to the last section of the Journal Club, and this is our special guest discussion. And we are incredibly fortunate to have Dr. Tim Yeatman. I think he is by far the most high-profile guest that we've ever had. And that's not only because he has his own Wikipedia page. And I don't think that I can do the list of achievements that he has justice, but as a very short summary, he is a pioneer in personalized medicine, having headed the development of the world's largest human tumor biorepository and database with comprehensive molecular profiling of approximately 20,000 tumor specimens. He is the current Associate Center Director for Translational Research and Innovation in the Tampa General Hospital Cancer Center. He is, of course, a professor of surgery in the University of South Florida. He has been continually funded by the National Cancer Institute since 1993. He has founded a novel biotech company called M2Gen. And one thing which I thought was incredibly remarkable, he was funded by NASA to oversee all scientific research at the International Space Station. So I'm very grateful to have the opportunity to ask him a few questions. So Dr. Yeatman, thank you and hello.
Yeah, thank you, Vladimir, very much for the introduction. Happy to be here and answer any questions you have.
Great. So the first question, I guess, is, as I've mentioned, you are the Associate Center Director for Translational Research. And so how did you gravitate to this component of academia? And what background do you think is required to be a successful translational researcher?
Well, all good questions. I can tell you my background is probably different from most of yours. I started out as an animal caretaker in NIH cleaning animal cages in the basement of Building 10. And quite an experience. But I learned a sort of a passion for research from, early high school and did summer research and so forth, and sort of got the bug and really carried that forward throughout medical school, residency a little bit, and then fellowship. Was able to do some of the research under the mentorship of others, which is a key part of this career, right? Having mentors to really take you forward. And then I got on my own when I got to Moffitt Cancer Center, and there is your sort of your cast there, like it was the first Whipple I did in the basement of Moffitt with an intern, and it was interesting, right? So you basically you're thrown out there to the wolves at some point in time. You've got to perform. So research is a passion, and it comes down to you deciding, what you really want to do, and then you got to go for it. I'm a risk taker. I've always been sort of a risk taker. And so I'm not afraid to try. As you can see in my career, I tried some different things. I moved around a little bit. And I wouldn't recommend moving around, though, until you've really solidified your career. I spent 20 years at my first job. And the value of that was tremendous. One, it kept my family stable. The kids all grew up in the same neighborhood and that sort of thing. I didn't jump from a assistant associate to professor at multiple institutions. I stayed where I was to climb that ladder. But in the process, I realized that you have to be different. You have to do things that are novel. You have to do things that are innovative. And that gets noticed after a while. And so when I was at Moffitt, by the way, Dr. Marcet and I had a paper that wasn't recognized, but in 2001 in Annals of Surgery, we published a local excision of rectal cancer after neoadjuvant radiation on a series of patients, with, by the way, similar results to this. And you can look it up, but you have to go to the library to find it, right? Because it's probably not even online. But anyway, I think, that's sort of what I can say about that.
Thank you. I guess you've mentioned doing a Whipples in the basement, which is scary enough as it is. My question is, how does one strike the balance between being a skilled clinician, given that particularly the technical demands of surgery versus, say, being a physician, and also being an accomplished researcher? And so how do you advise the young surgeons who want a career in academia, yet also want to maintain, a high volume clinical practice to find that balance?
Yeah, so number one, you have to believe in yourself that you can accomplish, more than one thing. I don't think people you can be good at 5 different things, right? You have to focus. So you have to pick your focus. So, when I started off in my career, I was trying to find a disease, right, that liked me. And I did breast surgery. I did the sarcomas. I was trained as a surgical oncologist. So I was doing everything. I was a hand surgeon, right? So I did everything I get my hands on. And Dr. Marcet and I were told to do colorectal surgery. Well, there were like 10 cases the year before I got there. So we had to build that practice, and we did it together. But, carving your time out is important. I think, if you're a medical oncologist, your week is 4 days. Surgical oncologist, the week is 5 days, right? And probably more like 7. So you have plenty of time to figure out clinic versus surgery. So I would recommend, you carve out at least a couple days for research. And that means then focusing on something that you choose you really have a passion about. If it's bench research, and you got to go to the lab. If it's translational research, you need to partner with people. And that was my other message to you, is that I've been successful in my career by always finding people smarter than me and not being afraid to, tell them what I think and learn from them. And, even in college, I remember I never thought I'd pass physics until I met this friend of mine, and he helped me get through it. But you have to find people that are smarter than you and be willing to work with them and learn from them. So that's sort of mentorship. And then networking. So today, research is done completely differently, right? So in my day, you had to pour gels, do Western blots, pour DNA sequencing gels and all that. Today, it's all, you send it off to a commercial entity and you have your sequencing done. Spatial transcriptomics I sent it off last month to Yale because we couldn't do it. I send my DNA sequencing somewhere else. It's a commodity. So don't be afraid of being able to do very sophisticated things. I didn't know anything about lipidomics until 3 years ago. Now I feel like an encyclopedia of lipidomics. But it just tells you if you really engage yourself in something and focus, and I do mean focus, most surgeons when they start are all over the place. They're scattered. And they're not sure what they want to do and how they want to spend their time. But if you try to focus and find out what you're willing to do, and again, whether it's clinical research, translational research, or basic research or no research, just go for it and make sure you focus on that. Have a plan, stick to that plan, and have some goals. Set those goals, set them higher than you think you can achieve. I've always been amazed that many times these grants, you put them in, you'll never think they'll come through. And at the very end, one comes through. So we've been continuously funded, blessed for that. But many times I thought we would never be funded. In fact, I was Xeroxing on Christmas Eve one time a grant, putting it in, and I got my reward, a week later or a month later from NCI. So I think it's dedication, it's networking, and today's surgeons have the power of AI and these AI tools, whether it's ChatGPT or Perplexity or one of these things, you can do research so much quicker than you could before today. And you guys may not be aware of like Perplexity, but you can pull in an entire paper into Perplexity and it'll give you a summary, like a bullet point summary in 2 seconds. You can pull a movie into it. You can ask it to write a poem for you. And there's all sorts of things you can do with these tools, right? If you use them properly. I don't know how English comp are working in college these days, because I don't think anybody's going to learn how to write. But the AI does really work for you. I did want to mention a couple things too, because you guys are talking about TME, but TME to me means something different, right? I had to learn total mesorectal excision, but also the tumor microenvironment. And as colorectal surgeons, I heard you talking about preoperative chemoradiation. I did this for many years, and we nuked people basically. And at the end of the day, you start counting the lymph nodes after chemoradiation. There's not many there, and you say, what happened to them? Well, they had radiation. Well, what do you think the radiation and chemotherapy are doing to the TME? And so I started thinking about that. And this gets to, how you need to sort of think out of the box. And I think, the findings that you can take an MSI rectal cancer patient and potentially cure them with a checkpoint inhibitor, that's amazing, right? No chemotherapy, no radiotherapy, no surgery, no ostomies. So that's the power of the TME. And so I believe that if we start harnessing, someone said the other day that surgeon and cancer surgeons, et cetera, need to become immunologists. And we need more. There are no immunologists treating patients, right? There's oncologists who know how to treat with chemotherapy and radiotherapists and surgeons who cut it out. Surgery will always cure people if it's contained, but if it's not, you need an immunologist. And they're really basic people, right? They know what T cells are, and there's T helper cells, suppressor cells, exhausted T cells, T regulatory cells, blah, 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 blah. But the question is, how do we harness the power of that TME to cure patients? And at the same time, I think we need to think of when we treat patients with chemotherapy, radiotherapy, even targeted therapy, we're pretty much wiping out the TME. And so you wonder why a recurrence after radiation to just go ballistic in the pelvis, right? And become totally incurable. Well, there's no immune system left there anymore. And it may be hard for that immune system to penetrate the fibrosis of a post-radiation event. So think about that as you go forward, because I think this is all going to change in your lifetime, where we will leverage the TME to greater and greater extents, like you've done for rectal cancer.
Thank you. It's an interesting point about the immunotherapy. Tarek Samura, one of the surgeons on the call, one of my Australian colleagues, he talks about the cancer being a software problem versus a hardware problem. And I'm sorry, he's made a couple of comments in the chat that I missed, but if people can have a look at his comments, that would be great to maybe have a chat discussion. But the other thing that I really enjoyed your comment about sort of finding people smarter than you, which I doubt that there'll be a lot there for you, but that's something I read from Marcus Aurelius's writings. So certainly it's something that wisdom has stood the test of time. Moving to my next question about you mentioned basic research, and I know that both residents, junior faculty, surgeons may take time out to work in the lab. I guess from your perspective or from your opinion, how long does one need at a minimum to take to work in a lab to understand how lab works? And after obtaining that level of competence, is it something that can stay with the clinician forever? Is it like riding a bike, or is it something that needs to be maintained throughout the career?
Yeah, so good questions. I think, probably a year, probably 2 years is what you need, solid 2 years. You could do it in less if you're there, truly there every day and spend all your time doing it and you immerse yourself with good people in the lab, good technicians and so forth. The mistake a lot of young people make is they go to the lab and they try to think the technician's going to lead them through the science. And it's not the tail wagging the dog. That never works. And people see through that very quickly. If you're going to be a PI, you need to really learn everything. And that means, if you're going to work for a trash company, you've got to learn how to throw trash. You got to learn how to run the truck. You got to learn how to do the all the different machines. Same thing here. If research, you need to learn how to do everything from the bottom up. And like take care of animals, right? I just took my animal surgery class and they're telling me how to do aseptic technique with animals, but you've got to do all that stuff, right? To get there. So don't be afraid to immerse yourself in the lab if you're going to do that. You'll find out pretty quickly in a year, probably you'll figure out whether you like it or not, and whether you like, answering questions and whether you get the bug. If you don't have it in a year, then you could probably get out. If you do have it, I'd stay 2 years. And a lot does stick with you. Knowledge is fleeting though. I mean, knowledge is always expanding. So like the stuff that I learned in the lab is no longer that useful. I have never done a northern blot since I was in the lab, and now it's all RNA-seq, right? We never thought that DNA sequencing could be done in paraffin. That's why we built that big 20,000 frozen tumor bank, because we thought everything had to be done in frozen tissue. Now it's all in paraffin, right? Even RNA-seq. So things change and you have to stay up with that. And I would mention to you too that the world's changing. So these technologies are evolving almost as rapidly as the AI. So now we talk about multi-omics or panomics. And so it takes 10 years, by the way, to get something into the clinic after it's been discovered. We did the first sentinel lymph node at Moffitt Cancer Center, and 10 years later, it was actually mainstream, okay? So I can tell you it takes 10 years to get anything even easy as a sentinel lymph node biopsy into mainstream. So anything discovered in the lab will take a long time to get there. But multi-omics and panomics is coming, where we're starting to look at, and with AI, right, we can look at not only the genome, but the expressed genome, so the expressed genes, that's RNA-seq. Single-cell RNA-seq is very powerful. Spatial transcriptomics, lipidome, metabolomics, and don't forget the microbiome. One of our faculty, Rick Jacobson, is now working on the microbiome. And I can tell you that, I can't tell you everything, but I can tell you that many of these tumors that you're cutting out locally, distantly, et cetera, have a microbiome with them, even in a metastatic situation that should be sterile. So even though you're thinking you're taking out a lung met or a liver met or a brain met, there's a microbiome with it that came from the colon. That's a fascinating thing to me. And that's sort of recently found by us. So I think you're going to see a lot more on panomics, all these things I just told you. And we now have the ability to integrate them. There's a man named Lee Hood, who I work with, who developed the Institute for Systems Biology. Again, me trying to aspire to smarter people than me. And I linked up with Lee at NASA and CASIS and that sort of thing. But bottom line is, the more you assimilate with these smart people, now I've met people at Amazon and Google and Microsoft and all the AI people. So you network and you meet more and more, and you build your reputation that way. So networking is very key. Finding people that you can honestly work with and be mentored by is very important.
Thank you. I guess this is a good gateway to talking about the biotech company that you've co-founded. I guess I find that the distinction between academic research, where that stops, and where commercial venture starts, is difficult. And I guess as a dedicated academic, did you always think that you would venture to start a biotech company? Was it a long-term plan? Did you somehow just serendipitously have a moment of discovery? How did that come about?
Yeah, it was more the latter. So long story short, we had done some gene expression profiling on colon tumors, and I had aligned myself with Craig Venter, and you might remember that name, and Tiger, the Institute for Genomic Research. Craig Venter was on Time magazine with Francis Collins, and they sequenced the genome. And I met one of these gentlemen at a meeting, and I told him I really wanted to do a bunch of colon tumors on gene chips, and at that time they didn't exist. And so Dr. Marcet and I were taking out hundreds of tumors and freezing them, and that was sort of a forethought we had, which was a good one. And we ended up putting them on these spotted microarrays made by a robot at Tiger, which is the company that did the shotgun sequencing that forced NIH to compete with them. And that's why the genome was done in a short period of time versus a long period of time. Those two were like, fighting each other like Fiddler Nicholson or some of these other DeBakey and Cooley, these big giants, right? These two guys fought to get sequencing done faster. And so when we did that, Moffitt was thinking about a big project, and they asked me to sort of pioneer that. And we talked to multiple drug companies to fund it. And the idea was they wanted to build something called total cancer care. And I wanted to build one tumor on every chip. And so we fused those two ideas. And I said that every tumor should be sequenced in some way. This was before sequencing. So it was the thought that there was going to be a great knowledge from molecular biology coming out of these samples. So every sample should have the chance to get sequenced. Now, today, we still don't even do that, right? We only sequence the metastatic cases. But I still believe there's a lot of biology and information on prognosis, diagnosis, response to therapy embedded in the molecular biology of the tumor. So we presented this idea to multiple drug companies, and Merck came along, and a guy named Stephen Friend, who founded a company, Rosetta, that was bought by Merck with Lee Hood, by the way. So these guys all in the same circle. So they founded this company. It was bought by Merck for $680 million at the time, which is a lot of money. And it was a company to do this chip sequencing, but they used inkjet printing to make it. And so it was an inkjet printing company called Rosetta. Merck bought it, but then they had no tumors. So they came to us and said, hey, you have 500 tumors. Could you get us more? And I said to Stephen, what do you mean by more? And he said, well, 20,000. That's the whole enchilada, he called it. So then he asked, what would that cost? And we kind of scratched our heads. We said about $100 million. And at the end of the day, they delivered a check for $100 million in $10 million increments. But it went into this contract. It was really cool with brackets that was empty. And then it became $100 million. So I was fortunate to witness that. But then we realized that we could not accomplish this at an academic center. Everybody was doing their own thing. The pathologist, the surgeons, everybody's doing their own thing. So who's going to sit there and do the work and have 9 Merck project managers? They're all PhD scientists breathing down your neck to get the job done. So we built a company called M2Gen. And at the time, Jeb Bush was the governor. There was state funding, and they were giving money away to Torrey Pines and to all sorts of places, to Scripps, to come to Florida. And it was a tax deal. So if you created jobs, you'd get money, and you had to have matching funds from the state and the counties and all this. So we applied for it, ultimately got it, another $50 million and some land. And now there's buildings and land. And there was a company called M2Gen. It ran the project for Moffitt. We bought robots to freeze, robotic freezers. We hired pathologists to prosect tissues and microdissect them. And we had to build a database with Oracle, the first one for human data that came out of Epic and Cerner. And that was a success. Oracle went and sold that to other hospitals. And so this company, just so you know, I had no stock options in it. I didn't get anything out of it other than it was a Moffitt solely owned company. That was probably my biggest mistake, not having some kind of equity stake in that. But it did give me the idea to sort of build things. And we've patented a number of things, and I've had benefited from patents and scientific patents. So that's kind of that story part of it anyway.
Wow. I don't think I've felt quite as inadequate for a very long time. But
yeah, it was fun.
Now,
it was
I
a fun,
guess to
fun
make
time.
myself feel even more inadequate, I have to ask you the last question, and that's about your involvement in the Center of Advancement of Science in Space. Now, this is particularly, I guess, pertinent because we've all just seen the astronauts that have landed after having quite a delay, and so they've had a prolonged stay in space, and as such have quite a lot of pathophysiological impacts on their bodies, due, I guess, to the gravitational field of the Earth. And so my question to you, I guess, what were some of the potential discoveries that may impact surgery from your time involved in the space station, if any?
Yeah, so the whole thing in the space station was I was in Tampa and I was doing pretty good science, and I got a call from a friend of mine and asked me if I wanted to be the chief science officer for a new non-for-profit Again, I've always been nonprofit, so don't get confused. And it and it was called CASES, Center for Advancement of Science and Space. And they were applying for a grant from NASA to run the science on the space station. So NASA had run the space station for years, but there'd been a lot of criticism from Congress that there wasn't enough good science on station. And they've done a lot of things. I mean, they sent everything up there you can. Remember, there's microgravity, there's extreme vacuum, and there's extreme radiation. So those are the physical perturbations of space. But really only microgravity is the one, because they're low Earth orbit in this space station. You actually see it, around if you look carefully at night. And so low Earth orbit, microgravity, it's kind of a weak force, but nonetheless it's a force. So CASES got the award, and they're still in business, by the way, to really sort out and develop a grant mechanism for science and space. So we developed a grant funding mechanism to review grants that were pitched out, and they would range from anywhere from $2 to $3 million a grant. And the money would go, a lot of it would go towards packaging the experiment for the space station. It had to be bundled a certain way. It had to be inserted in a little metal canister that would plug in. Everything had to be plug and play, because once to get it on the station, and it would just have to be put there by a force of people to get it up there. So interestingly, probably the coolest thing done was crystallography. So they were able to crystallize a protein that very hard to crystallize up in space, better than they could on Earth, and with better crystal structures. I think it was Huntington's chorea protein. But they did a number of crystallography experiments, and I think that's turned out to be the best use of microgravity. But there were flame retardant experiments, creating foams, creating foam cell things that were better. There's a lot of physics involved, stuff that I didn't understand. But we got review panels involved and scored the science as you would like NIH, and the science got awarded and would eventually get flown. But you can imagine there's been all sorts of things that have gone up there, and it was a fun time. I got to meet Julie Robinson, who was the NASA's chief science officer, and I got to meet the head of NASA. Got to watch some launches. So a lot of fun stuff. Got to go to Kennedy Space Center multiple times. So.
Well, that's incredible.
Anyway.
I was born in the Soviet Union, so it's very hard to shed that bias. And I do remember that when the Americans invented the anti-gravity pen to use in space to record things, the Russians or the Soviets just used a pencil. And
yeah, but the Russians invented the STPU instrument. Do you know what that was? That was the first staplers. The first staplers were invented in Russia.
Oh, of course. Yeah. I guess it's a different story, but that would be the most
far greater use
thing of surgery, I guess, to make everyone use the same thing. Very. Anyway, no, thank you very much for your time, and thanks the whole team from South Florida. I look forward to hopefully seeing or meeting some of you face to face in ASCRS this year, but if not this year, then definitely next year. Thank you all, and for our viewers, it's going to be recorded and shared on the DCR YouTube channel, so thank you for supporting us.
Thank you, Dr. Bolshinsky, Dr. Kalandic, and everybody else for the invitation, and thanks for everybody online. Really appreciate the discussion and look forward to meeting you all in the future as well.
Thank you.
Take care. Bye.
Bye.